Good evening, everybody, or good afternoon if you are in the US. Welcome to HARC's Oral Abstract Session B. My name is Orkan Okan. I am from the Department of Sport and Health Sciences at Technical University in Munich, Bavaria, Germany. My main area of research is health literacy. And it is both to me a pleasure and also an honor to be the moderator of this session. And I would also like to welcome our four distinguished speakers, Jennifer Innes, Veronica Juan, Wieke van Boxtel, and Amy Faust. I will introduce each speaker in a bit more detail right before their presentations. But before we move on to their presentations, let me give you some just brief technical key information that are relevant to our session. So each of the speakers will speak for about 10 minutes. This will be followed by a Q&A for approximately also 10 minutes. You can post your comments in the chat. Once we receive the comments, we will then read your questions, right? Or can they also say them out loud? I think you have to post them and we have to read your questions.
If there's time, they could raise their hand, scan it, can unmute them.
Oh,
but
great.
There may not be time. We'll see. Yeah.
That is great. And in case there should be time after the four presentations, then of course we will have an open discussion. But let me just move on to the first presenter, Jennifer Innes. Jennifer is Assistant Professor in Teaching Stream in Nursing at the University of Toronto in Canada. Her main field of research is health literacy and interprofessional education. Today, she will present her research on nutrition literacy and post-secondary students experiencing food insecurity. Welcome, Jennifer. We are very much looking forward to listen to your presentation. The floor is yours.
Okay, good. Thank you. So as you said, I'm going to be looking at nutrition literacy and post-secondary students experiencing food insecurity. I think everyone is aware worldwide there's been growing attention being paid to food security. It's an issue globally, and there's been a great deal of increased research in this area among post-secondary students in North America. I'm speaking about North America largely because most of the literature looking at food security in students is from Canada and the United States. In Canada and the US, the rate of food security among the general population is about 10%. Post-secondary students, it actually goes from 20 to 82%. Obviously, being food insecure is not good for our health. It's been found to be associated with increased rates of mental health issues, lower chances of finishing educational programs, and lower ratings, self-ratings of physical and mental health. This study took place at Centennial College, where I worked full-time until a year ago. It's a large community college in Toronto, and like many community colleges, I think, in North America, located on the outskirts of the city, although maybe unlike many, it is in a food desert. So the area around the only available food was across the street if you wanted to leave the college, and it was a hamburger stand in the gas station. They also had a cafeteria with very expensive food. So my co-author on this research study, Michelle Bishop, is a professor in the Food Services Management program. And she got approached by the biotechnology program, the chair, who was concerned about nutrition and hunger in his students. And what they were finding out was several times a semester in the late afternoon, students were passing out. Emergency medical services had to be called, and in each case, it was low blood sugar. It's a very demanding program. These were students who started at 8 o'clock in the morning, and they could have labs going until 10 o'clock at night. So Michelle and I got very interested in this, obviously. And we started wondering, what's causing this? Is it food insecurity, or is it nutrition literacy? And that's what led us to investigate. So we know that there's multiple components that make up nutrition literacy. It has to do with how to find and prepare food, how to prepare meals, how to find out about health and nutrition, and also self-efficacy, our confidence in being able to prepare healthy food. We found that this group of students in the biotechnology program had a very high rate of food insecurity. More than 3/4 of them were food insecure, and just over 1/3 had severe food insecurity, which led us to wonder, what role is nutrition literacy playing? And that led to our research question: what's the level of nutrition literacy among this group of post-secondary students that has such a high level of food insecurity? We did a mixed method study. We had a survey which used adapted questions from the Critical Nutrition Literacy Scale, which measures engagement with information about nutrition, as well as concerns about barriers that exist to healthy eating. We also used focus groups to ask students about their experiences with healthy eating and how they found out information and how they made decisions about what to eat. And we had a great response. To the survey, our response rate was just over 40%, and we had 6 focus groups with a total of 30 students. The scores on the Critical Nutrition Literacy Scale were low. Our overall score was about 30%, and these were the items that were amongst the lowest. So overall, students, according to the scale, indicated that they weren't engaged in information about nutrition and health and weren't concerned about the lack of healthy food that was available at the college or in that neighborhood. But in the focus groups, we found a slightly different story, as you often do when you do mixed methods. The students, participants, had a clear interest in healthy eating, and they spoke about trying to balance multiple responsibilities with having to shop for food. About half of the students in our sample were international students, so many of them, it was a case of finding out where the international supermarkets were, how to cook food, how to prepare and do grocery shopping and manage all those tasks in a brand new environment. In each of the focus groups as well, students said that they needed education. They said that they would benefit from having workshops that went over not only how to cook, how to find healthy food, but also financial literacy, how to budget for food. And the relationship between nutrition literacy and food insecurity is backed up in the literature. And other studies have also found that we need student programs that focus on nutrition literacy. There haven't been a huge number of studies that have looked at nutrition literacy and food insecurity. And the ones that have been done, it's really all in the last 5 years. But what they have found is that low food security generally goes with low nutrition literacy, and that programs can help alleviate that food insecurity. A particularly interesting program was at Appalachian University, I forgot the name of the school, but it's Appalachian something University. And they had a nutrition literacy program that lasted about a semester. And they found that while they weren't able to significantly reduce food security levels, they did improve significantly food secure behaviors. And by that, I mean self-efficacy in cooking, preparing food, making decisions about what to eat. The last reference there on the page from Mattis et al., this was a larger study in a California public university where they implemented a semester-long course that used lectures as well as labs in the kitchen, where students actually learned how to prepare food, as well as attending lectures about how to shop for food, how to make decisions about what to eat, and how to actually go about preparing that food. They were able in this program, they decreased food security levels. They had a high level of 70%. After the program, the rate was 48%. For students who were very food insecure, their levels dropped from 23% to 6%. So clearly there is a role for nutrition literacy programs to meet the food security needs of our post-secondary students. We need more research, though. Those are only a couple of studies that have shown the benefits. And clearly, when we look at these programs, we need to make sure that we're including students because we need to make sure that we're meeting their needs. There's also been the point in the literature as well, though, is that we can't ignore that food security is an economic issue and that schools have a responsibility to ensure healthy and affordable options are available. International students are actually helping the budget lines of post-secondary schools throughout North America. And the schools spend a lot of time recruiting students without making sure that they have the supports in place when they come attend their school. One of the criticisms about focusing too much on nutrition literacy is that we're ignoring the point that there's a lack of economic supports for post-secondary students. I included a reference to the SNAP program, which is often more commonly known as food stamps in the States, because I know most attendees at this conference tend to be American. One of the problems with the program is it's really difficult to be a full-time student and access SNAP. You generally have very stringent work requirements, and the application process itself is daunting. So just to underline that when there are economic supports available, we need to make sure that they're actually accessible to students. But it is not an either-or situation. Clearly, there's a need for programs that address nutrition literacy. And it's exciting to see that the programs that have introduced nutrition literacy programs have had a real significant impact on students' food secure behaviors. Thank you.
Thank you so much, Jennifer, for this very interesting talk. Actually, I have learned a lot of things that I wasn't aware of. Thank you so much. I will surely contact you after the session.
Okay.
So are there any questions? Unfortunately, I don't see the other participants. I mean, I can see them below, but I don't see them in the picture. So if they raise their hand, I wouldn't see that. How will I know if anybody has a question? Maybe if there is a question, if you could just post it to the chat and then I will read the question to Jennifer. Maybe this could be our solution for this tiny problem.
Or if there's questions at the end, that's okay too. Sorry,
but if nobody has a question, I am happy to ask a question because I find it so interesting. So in one of the last slides, you mentioned that focusing on education won't solve the problem. Then the relational model of health literacy popped in my mind. So you said food is an economical issue. Do you think that if we would aim at providing some sort of financial support to students, to families, that would do? Or is it really only a matter of financial literacy? I'm in particular thinking of the organizational health literacy approach and making schools health literate and having a dimension that addresses that.
It needs all of those approaches, I think. I don't think it's enough to introduce the nutrition literacy if you're not introducing the economic. On the other hand, just introducing the economic isn't enough either. There's been historically most post-secondary schools now have food banks or food lockers, some kind of food support programs. I mean, on the whole, these tend to be a bit inadequate, but they themselves haven't been found to be enough. So we do need to combine it with education. Also with, as you point out, the colleges and universities need to have an organizational health literacy approach to this to meet the needs of their students.
Yeah, thank you so much. I think that will be very important. I was just informed that if audiences have questions, we have a specific Q&A tab. You can also post your questions there, but I don't see no question at the moment. Maybe just one final question from me, because really your talk was very important. In one of the earlier slides, you mentioned that in emergency cases, it was found out that most of the students affected had low blood sugar. Can you provide some more information about that, please?
Oh, yes. I think it's because I'm a nurse, so I assume everyone knows, sorry. the students had low blood sugar. In each case, they had not eaten either all day or since about 6 o'clock that morning when they had left home to come to school. So that was why they had the low blood sugar. Sorry, I went over that too fast.
Then I totally get it. And since you are talking about both school-age children and students, and also university and college students, I know that you have the national health education standards in the US, and in these standards they are aiming at excellence in health literacy, promoting health literacy in schools. Do you think that this kind of education and training on nutrition, food literacy, and also financial literacy could be embedded into that curriculum that you have in place?
I think it'd be great. We don't have that in Canada. We have sort of pockets of similar educational standards in Canada. I think that would be, I can't see how that wouldn't have an impact, but I think it might take decades to find out.
Yeah, apologies for 1 second. I just placed you in the US. Of course, you are from Canada, and you are right. There is no health literacy curriculum. But I can see a question from Jill Hecker Fernandez to you. What about international students who attend a school at rural locations?
It was international students, they said, right?
Yeah.
So even though this community college is in Toronto, it's on the outskirts. So it's not a rural location, but there's not a whole lot of resources around there. Even more, but there are international supermarkets. It's even more difficult in a rural area where there often lack international supermarkets and resources for students. I think in those cases that the schools have to make a huge effort to meet the needs of the students. I think they're spending, we know they're spending millions of dollars recruiting students to come to Canada, especially from India, and then not providing the students with resources when they get here. At least that's an issue in Ontario, the province I'm in, where students are heavily recruited from India.
Great, thank you so much, Jennifer. And now it seems that the questions are coming in. From Carol Howie, you have a high proportion of students who are food insecure and were willing to share this. At my typically wealthy school, students are embarrassed to reveal that they are struggling.
Oh, well, actually, the research bears out that students, when they respond to these surveys, do report high rates. I mean, it's quite a range from like 20s to the low 80s, but.
Right.
That's interesting that they're embarrassed. Yeah.
Yeah. Sometimes
the numbers we're seeing might be lower than they are then.
Yeah, there are some study findings from the 90s and early 2000 years regarding health literacy and shame. We can see that this is an issue and also stigma. Right, there is another comment, but it's just a comment. You can see it in the chat box. But it's great that the questions are coming in. That's so nice that we get the flow here. Let me just check if there are any more questions, because I believe that we have 1 or 2 minutes for additional questions still left. Okay, it seems that at the moment there are no questions, and also maybe I'm asking the other presenters, Amy, Wike, and Veronica. Maybe if you have a particular question, you're also welcome to ask Jennifer, just in case. Okay, that doesn't seem to be the case. Jennifer, thank you so much for being with us and presenting these interesting findings on nutrition and financial literacy. And I'm really looking forward to access some of the papers that you had in your presentation. See you in the discussion after the presentations. Bye-bye. Okay, so now we are moving on to our next presenter, Veronica Juan. Veronica is a medical doctor and an assistant professor at the Department of Pediatric Emergency Medicine at Children's Wisconsin in Milwaukee. I think that's Wyoming, United States. Quality improvement and health literacy. She will today present findings on antipyrectic prescriptions and education at an emergency department visit for fever in children 2 to 24 months, increase confidence and reduce return visits. That's a complicated name. I hope I spelled it all right.
No, you did it. It's a
Veronica.
very long title, so thank you for that.
It's a great title. Thank you so much for being with us this afternoon, and we are very much looking forward to listen to your talk. The floor is yours.
Of course, thank you. Let me share my screen. All right. Okay, so I'm a pediatrician. As an introduction, I work at the emergency room at Children's Wisconsin. And so really this came about earlier last year, especially in the pandemic. Fever is the most common chief complaint we have for children coming to the emergency rooms in the United States. About 30% of visits are related to fever. A lot of return visits are usually within a 72-hour window. We find that parents are often concerned about higher measured temperatures, how long the fevers have been lasting for, and as well as what their child looks like with fevers, oftentimes looking a lot more tired, not interested in eating or drinking. Typically they say like lethargic or irritable. And so it often concerns them for something a lot more serious. And so they often bring them in within that 72-hour period. We use Tylenol and ibuprofen here to treat fevers, but we do realize that up to 70% of families will make dosing errors, especially with Tylenol. Oftentimes they'll measure with a spoon rather than a syringe, and also on over-the-counter medications here at our pharmacies. For Tylenol and ibuprofen, for any age under 2, it says ask your pediatrician. So there's not clear information that's standardized here in terms of a weight-based dosing, which is how we give medication to children. Again, some of the other concerns that families would want to bring their child in for fever rather than treating at home is whether they can afford the medication, or if they're able to go to the pharmacy and obtain transportation to get said medication, lack of instructions, how often to give it, how much to give, and certain age limits as well. And then again, fever phobia, especially in the day and age of a pandemic. So we sought to answer if we gave medication education about Tylenol and ibuprofen, as well as provided families with discharge instructions, would that mean that families would feel more comfortable managing the fever at home and therefore reducing return visits to the emergency room? So our focus population was children that came in with a chief complaint or a billing discharge diagnosis of fever. Specifically, again, our target age was those less than 2 years of age, knowing that they would not have clear weight-based dosing obtained anywhere else. And then these were non-urgent patients that were seen in our emergency room. So typically they're called a triage level 4 and 5. So anyone coming in with cold symptoms or vomiting, more of a viral illness, or even like an ear infection, but nothing where they were a complex patient. So we assessed around 5,000 patients that came in from October of last year to May of earlier this year. And this was assessed by a quality improvement team, so both physicians and nurses. So we sought to figure out ways that we could improve the education. So our biggest branch that we were focusing on was in providing family education, focusing on health literacy, was to make it as simple as possible. So the that image over on the right hand side that is in blue, that is a magnet, about a 5x7 magnet that actually goes on the fridge. It is weight-based dosing for both liquid and solid for Tylenol and ibuprofen. So as long as they go to any pediatrician or go to any clinic and have the weight, then they can compare. It does not have to be necessarily through the emergency room. And then the sheet on the left, which is in white, is a pictogram. So we didn't want to assume anything about the health literacy of our families. So we provided this pictogram as well with syringes so they could see what it would look like when they were giving the correct dosage. We created these packets and then put them in an area where we knew was going to be the most efficient workflow area, which is right by our discharge printer. So nurses will just grab these packets as they grab the discharge paperwork and then provide this information to the families. We also looked at what was going to be the best placement for both nurses and physicians so we could provide the discharge prescriptions. And so what happens is when families check in during triage, as the nurses ask, when was the last time they gave any Tylenol or ibuprofen? They'll then also ask if families would prefer to have those sent as a prescription at the end of their visit. And if they say yes, then you can see in this little image here, it will pop up for the provider. And so we just click order and it auto populates and we send it in, and it just takes very minimal time from either end to be able to provide the families with this resource. We did survey families before and after interventions via callback nursing, and then we compared the results with a chi-square analysis. And then we also did a real-time chart review, again, looking specifically at those with a lower acuity coming in with a complaint of fever less than 2 years of age, compared on a P chart. Prior to our interventions, we had 45% of family that obtained discharge prescriptions and felt that the majority of them felt that it was very helpful. So our aim was to increase the number of families that were obtaining discharge prescriptions, which did pop up to 58%. And again, the majority, the 84% of families felt that this was helpful. Education during the visit and at discharge remains similar when we were comparing numbers. More significantly, families did feel quite a lot more confident administering these medications at home. And this was statistically significant when we ran the numbers. So 72% of families received discharge prescriptions and felt confident versus only 45% of families that did not decline discharge prescriptions felt confident within the 72-hour window. And again, once they got education, 82% of families that received education during the visit and at discharge felt a lot more confident with the packets, and 11% of families that declined the education did not feel confident. So interestingly enough, granted, this is only within a 6-month window, but we did see that while there was not a significant change in the 48-hour window, we did see that at least within the 72, 1 week and 6-month return visits, there was a significant change, about 3 to 5%. So in conclusion, parents felt a lot more significantly confident when they received education in the visit, and then when discharge prescriptions were sent, especially with these weight-based pictograms and magnets that were provided. It should be noted that the magnets are actually very simple and very cheap to make, about 70 cents per magnet based off the packets that we made. So providing families with these simple, cost-effective tools led to a decrease in return ED visits just based off of the increased confidence of giving these medications at home. And this is especially for, again, families where the over-the-counter labels are not clearly available for them. So in the future, our hope is to collaborate with nursing on how to improve the rates of education during visit and at discharge. So we're still working with our quality improvement team, and then obtain further funds to create more magnets and packets for these families. Any questions at all?
Thank you so much, Veronica, for this great presentation. And let me just check the Q&A if there are already any questions from the audiences to you. At the moment, there are no questions, but maybe I can just talk to you a bit. Maybe the others are just typing as we speak. Yeah, fever is one of the most complaints of children presenting in ER when they are between 2 and 24 months old. I really didn't know that. And you mentioned that the number might be much higher, but a reason for not bringing children to treatment is something that we just heard at the Zoom in the earlier presentation, is a lack of financial resources, right? And also education. Can you delve into that a bit, please?
Sure. So we do know that at least in our population, a lot of the families are often based off of more like welfare or government. So actually when we send the discharge prescriptions is actually covered by their insurance. And so I think a lot of that was, the accessibility of it. And then once they had the accessibility of whether or not they understood whether to use it or not. So I do see a question about how to sustain it further. And so our hopes is to kind of do more of a widespread community outreach. So I actually did meet with a couple community leaders earlier today to kind of hold talks for families so that they have a little bit more about fever awareness. And then if we can provide them with these packets, it would necessarily, not necessarily focus more on reducing return visits, but if anything, reducing the initial visit of going to the emergency department for a fever if they are already given this information. Our hope is to standardize this information where we can give it to different hospitals, children's hospitals, and have it become more widespread. So we're all using the same. So it's not that they're getting different information from their local pediatrician and also getting different information from us as well.
Yeah, Veronica, thank you so much. So I think you have just answered to Alison Caballero's question, right?
Yes.
But there are a couple of more questions. Mary Ann Abrams asks, did you say whether you use teachback during the education with the packets?
That's a great question. So oftentimes the nurses would go in there and walk it through with families, and then not so much a teach back, but just ask them if they had any other questions or if there was anything else that we could answer for them at the time. So not necessarily a teaching session per se, but our hope is to do that. If we do it as a community, then that way it would be more of like a workshop where parents can come in and ask those questions and really have that Q&A session in the community.
Right. And Jill Hecker-Fernandez asks, did you use showback?
We didn't necessarily use showback, but we did, again, evaluate more the teachback and the showback when we had called families afterwards and asked them how they felt about confidence. And we did ask them, how often are you giving the Tylenol, ibuprofen? Do you have any questions about the prescriptions that we've sent for you? And then, have you had any difficulty using the resources? So we had kind of asked pre-intervention just to really make sure we could cover any concerns that parents had about how easy it was to understand the medication that they were giving.
Right. And there are a couple of more questions for the next one. I actually don't see the name, but have you done any health literacy research with patients with T1 diabetes?
Oh, I have not, but I do know that in terms of our quality improvement team, our next step is working with asthma in terms of how often to give albuterol and understanding when to give steroids and when to come back for that.
Right. And the next two questions, they come from Amy. Do you have data on how many of these were first-time parents and effectiveness for that subgroup? That's the first question. When you answer it, I will read the next question.
We don't have any data yet about first-time parents, but we are interested in also evaluating how many of these are also parents that have multiple children, just because we do find that some parents will use inappropriate dosing because they're using the prior prescription for a different sibling. And so our hope is we can kind of ascertain some more data and kind of shift through that and figure out what's the best way to address families that have our first-time parents and with multiple siblings as well.
Yeah, great. It's in the sense of a whole of family approach, very important. And then her second question is, do you know how many have the pediatrician versus relay on emergency department for primary care?
Yeah, that's a great question. So I do know, I don't have the statistics, but I do know that the majority of families currently rely on the ED for primary care. Unfortunately, with the pandemic, there has been a lot of shortages, at least through our pediatricians that are operating through children's, that they don't always have the available sick appointments or acute care visits, I should say, for those families to come in when they have an immediate concern. So then the draw is to go to the ER because it's a lot faster. They don't have to wait 2 to 3 days before seeing their pediatrician.
Right. And there is another question from Mary Ann Abrams. She's asking, is time such a barrier that staff can't use teachback showback at the end of the visit? Seems like it would be such a helpful addition.
Yeah, I definitely agree. It would be a helpful addition. Discharge instructions, I agree with Peg. They are oftentimes rushed a lot of the times, at least where, for the lower acuity, our focus is to, at least for the department, is to get them in, get them out. And so we are trying to figure out ways where we can make it a little bit more sustainable with the families. And so on our part was reaching back out to them the next day just to see how the last 24 hours were going. Also, unfortunately, at least in the United States, there has been a nursing shortage in a lot of the emergency departments. So we don't have the same familiar clinical ancillary staff that are there consistently. If anything, it's we do get some float nurses or travel nurses, and so they don't necessarily have the same training. And so again, our team is working with the nursing administration to see how we can standardize it, whether it's like all the nurses have to take one short class on talking about discharge instructions and how to provide that information, again, so that it is a standardized and not just whatever they are used to, but being in a different environment, not in the emergency room.
Yeah. I think this points towards that we need to invest much more in infrastructure and training of nurses, and also increasing the working conditions. And there's also a comment by Peg Hickey as a response to Marianne's comment, and she says that as a clinical nursing instructor, she knows that discharge instructions are often so rushed, and it seems that the two of you just make the same experience in the same setting.
Yeah, of course.
Yeah, great. I really love it that we have such a lively discussion, and we still have a couple of minutes left, and maybe there are some other comments and questions to your findings. Let me just see I'm looking at the chat, but maybe there are also in the Q&A tab some questions, but it seems these are the old questions. Maybe just one final comment then by me, and maybe in the meanwhile someone else can post there is one by Jill Hecker Fernandez. She says it's just a comment. Kudos to your group for the innovation to meet needs of families, and I totally second that.
Thank you.
Yeah, that's great. Just one comment, because there was one particular slide I really liked more than the other slides, and that was with the leaflets for the refrigerator. Yeah. And I thought it's a great way to use figures and graphics, and also show how many of the medication needs to go into the syringe to use at what age. And this actually is a great approach.
Thank you. And we actually really worked with our pharmacy team to make sure that it was in whole numbers. I think practicing in medicine, it's quite easy to just prescribe something, but when it comes out to point something and it's in dot like 3.23 milliliters, is really hard for families to understand and give the correct dosage. So we wanted to make sure it was a whole number, easy to understand, but then would not be underdosing or overdosing for children of that weight. So,
right. And when you presented the second figure, did you say that on purpose you have not included a health literacy there, but rather made it about the information that you deliver?
Yeah, so we didn't want to assume that parents would know if we told them how many cc's to then measure it out in the syringe, knowing that, not English is not everybody's first language. And then again, if you're a first-time parent, you may not know how to necessarily draw the medicine and what it's supposed to look like. So that's what we wanted to make sure that it was very clearly understood.
Yeah, and then there are some comments. I think they have no questions, but Brianna says that she loves this. We recently worked with a pharmacy in the pediatric ED for similar handout with weight-based dosing. I love the idea of adding the order set for physicians. And Peg says she's researching nursing knowledge and experience, very important, with health literacy. And unfortunately, there's a big gap. There needs to be education. I also totally agree with that. And Michael says that Shona Yins, oh yes, she worked a lot of that work, exhibited these measurement issues extremely well. Okay, we will revisit Shona Yins' work then. Okay, Veronica, thank you so much for this great discussion and also the presentation. Please stay with us. Maybe there will be a discussion after the session. And now we move on to our next presenter, Wieke van Boxtel. Hi, Wieke. Wieke is a PhD researcher at the University of Applied Sciences in Utrecht and Amsterdam University in the Netherlands in Europe. Wieke has a master's degree in health professions education and a bachelor's degree in dental hygiene. Her research focused mainly on health literacy in children aged 9 to 12 years old within the context of health promotion. And the title of her presentation that we will listen to is Content Used to Describe or Measure Health Literacy in the Context of Health Promotion for Children Aged 9 to 12 Years, based on a scoping review. Wieke, thank you so much for being with us, and I really look forward to learn from your research. The floor is yours, please.
Thank you very much. I will share my slides. Hopefully they go into presentation mode. Yes, we are here. Okay, so thanks for the introduction. Now I can immediately start with a disclaimer. These results that I'm presenting are preliminary and are not peer-reviewed yet, but I have no conflict of interest. But let's dive into the background. well, we all know that in the recent literature, for children to grow up and stay healthy, they need to be health literate. And increasing health literacy levels in children could be seen as the opportunity to a more health literate future generation. And however, worldwide, various definitions and a variety of operationalizations of the construct of health literacy are described and used in assessments. We are not yet there to know, for instance, in health promotion, what we should use to operationalize the construct. So therefore, the purpose of my scoping review is to gather relevant content and provide an overview of this content used to describe or assess health literacy in the context of health promotion in children aged 9 to 12 years old. And the methods I used a scoping review because for learning and to improve health literacy, education is also needed, as is heard before in this already interesting conference. And to make sure that we include also educational literature and reports, we used a scoping review design, but we also used the PRISMA guideline for scoping reviews to make it systematic. So we did a comprehensive search of a few databases, and we searched the original search till 2020, and we updated it this year until August 2022. And for the screening and selection in the original search, we use Rayan for title and abstract, and for the update, we used AF Review, which is artificial intelligence and active learning computer system that helps prioritize the found literature. And as you can see later, I will explain why I used this. For the full text selection and data extraction, we used Confidence, and we extracted the data, the descriptions of topics in the construct, and the operationalization of the construct within the literature found. And we then did a deductive qualitative analysis on these texts, operationalization of the construct text, based on the competences definition by Sursen, the learning outcome definition by Bakari, and we used the HL levels of not being as well. So the results. As you can see, we started off with a large amount of studies, and therefore in the update, we at least found another 2,000, and therefore we used the artificial intelligence AR's review system to make sure that the update went a bit faster, and was based on the original selection procedure, and therefore was also reliable. And we searched for a bit more constructs than only health literacy, because based on health promotion, we think that healthy movement, non-sedentary behavior, food and nutrition literacy, as well as media digital literacy and other health literacy constructs regarding health promotion are needed to be looked at as well. However, for this scoping review, we included 26 articles, and a lot of number of articles also could be included for the other construct, but we will go on in another publication for that. So we included 26 publications, and mostly were research literature. The red ones were educational program designs, and 2 government reports for educational standards. And in our results, what we found was that we were looking at the distribution of the constructs used within the operationalization of the data. And we saw that there was almost an equal divide between the construct of competences by Sørensen and the learning outcome definition. And we, for the levels, we saw a big group of cognitive skills and critical skills in the data. There were also different settings found in the data, mostly school settings in which the information was found, after school settings, but also daily life. And there were some overview studies with multiple settings and a public setting as well. So when we looked at the content, so the operationalization and the concepts that were used, we see here the information about that, and we can see that health and information are mostly found, but also can and understand and skills were found a lot. And the other words that we can see are the concepts that we found, and therefore we needed to do a deeper search and analysis, and we did. So we found here the top three topics of the HL construct codes and levels that we found. And what was striking for us was that disease was in the top three of two of the skills. So in the critical thinking learning outcome of Pakari, and also in the cognitive skills, so that we see that in health promotion, even disease is looked at that as well. Otherwise, we found that there was a lot of learning aspects and ability aspects, but also products and services that will that we found in the topics that were used most frequently. So as we look at this very big concept, it's the link, the co-occurrence of all the codes that we used. And what we see actually is that co-occurrence is very often seen between understanding and knowledge, of course, which is logical, and also very often between applying and use and apply information. And understanding and comprehension is also found very often. And to quote some of the sentences that we found in there, so for example, in critical thinking and analyzing information critically, so that's between the construct of the learning outcome and an HL skill, we found that the quote, the student will be able to identify at least 3 reasons a healthy agency, organization, or institution would be considered a credible source of health information, services, or products. So we gave words to these co-occurrences by using a lot of, getting out a lot of quotes of this information. To the discussion of our research, the publications in our review described or assessed health literacy mostly in school settings, and the educational aspect was present in the vast majority of the included literature. We found that in China, Germany, Finland, and the United States, HL is used as a learning outcome of education or health education programs, and we could learn a lot from their descriptions. What we also found was various topics and operationalizations are used, which was priorly mentioned also in other reviews, but we wanted to give a bit more insight into the topics that were used for the contact and in the operationalization. And what we did find was that almost all content could be related to one of not named levels. On the other hand, the constructs describe the definitions used by Sørensen and Pakari have provided the field with a broadly applicable definition. So we could use actually these 2 definitions on almost all publications to find relevant information. Of course, there are some limitations. For this scoping review, we only focus on the content in the description or measurement of the constructs. And in the search terms, we used the word measure or assessment. And that could mean that we have missed some of the literature which did not imply a measure or assessment. Otherwise, we have not evaluated the methodological quality of the studies. However, this is partly done by a number of colleagues also present in this room. And another limitation is that we have used 2 different selection processes for the original search and the updated search, and we have not analyzed all the data with the 2 researchers for that. But in conclusion, we recommend using the results of our review to find input for the operationalization of HL in learning outcomes and competencies in children aged 9 to 12, and look at it, what they should acquire to growing up healthy. Further research would be aimed at the use of appropriate content in the learning and assessing of HL skills, and the target population should be participating in the development of instruments and learning materials or formulation of learning outcomes in order to use or guide to the appropriate content that is used in our research. Of course, the references of the scope and review. Oh, something's going wrong. And the acknowledgements for my supervisors and my peers. And if you have any questions, you can ask them now or contact me later. I will stop sharing.
Wow, thank you so much, Wieke. Since I am doing research in the same age group, that was a wonderful presentation, and I again learned a lot. Let me just check the Q&A tab and also the chat if there are already questions to you. Maybe people are just typing their questions, and then in the meanwhile, the 2 of us can maybe talk. You mentioned how many definitions there are available. You particularly focused on Sorensen's definition on comprehensive health literacy and Pacari definition from their school curriculum, right? Because they have this school curriculum on health literacy in place. And you mentioned that there are so many definitions on health literacy. And I just read a paper by Malloy Veer and colleagues from North America where they chronicle the definitions and models, and they find more than 250 definitions and models. That's a lot, right?
Yeah, that's very much that, and also very difficult to work with. Otherwise, all those definitions are similar and have 1 or 2 small differences or focus points that are different, but that's why we chose the Sorensen definition for the life course, because that is something that in the measurement instruments is seen recently to be used. And otherwise, for the educational part in growing up in this age group, we found it very important to incorporate a learning outcome definition for that. So that's why we chose those 2.
Right. And does the Dutch education system has a school health education or definition of health literacy in place?
Not yet. No, I read that they are asked about the health literacy definition from the health promotion perspective, the organizational perspective, but not there was not a really clear definition for children yet. And that's also what we've seen in other studies that we are doing, that the children we are working with, they know what they like and think about the content. But if we ask it, for instance, in the educational setting, they don't really know what they are doing, but they are doing something already because they learn the critical skills they need for some health behavior or some decision making they are doing based on their health. Yeah.
I totally agree. As one of the major results of your scoping review, and I'm really looking forward to read it, you had this complex figure, this graphic, where you relate all the different competency and action areas. I find this was very convincing, but what do you think? How can you translate that into an intervention on school level? Because this is providing something very new we haven't seen before, relating all the different approaches. What can you do? And also, what can you do? What are the chances for you and the Netherlands to bring this into your school system?
Yeah, what we are now doing is that we are also talking to children based on what we have found, for instance, in the measurement instruments. And the topics, are these the topics that the children also seem to be seem relevant for them? And what we are finding now, it's also in the poster on this conference, is that those do not match completely. So what we see in the literature, for instance, is not really what we see in the Netherlands is working. It's regarding safety measures for wearing helmets on bicycles, for instance. That's just not a thing in the Netherlands. The safety exam is only for 11, 12-year-olds. So if we look at 9 and 10 and we ask those questions, they are like, we're not having that. I don't know. So that's stuff we are looking into now to see what skills the children learn in the schools already regarding the health literacy they should be learning, for example, in the definitions. And then we are going to look at how can we do make it into or a measurement or a learning opportunity for them.
Yeah, Mieke, thank you. You mentioned something very important, to link health education or health literacy with traffic education, because here in Germany, in a certain age group in childhood and adolescence, this is the most common, traffic accidents are the most common thing when it comes to childhood or adolescent deaths. So that is something we should take very seriously and link with health education. I'm checking the chat and the Q&A. Maybe in the meanwhile, somebody has posted a question. If not, I have one or the other left because we have 1 or 2 minutes still. But I don't see any questions. Maybe then my final question. You mentioned an AI system, a software that you have used to pre-select software. I've never heard about something like that. Can you tell a bit more about this, please?
Yeah, I can. I expected this one. That's why I really mentioned it, because it was, for me, it was a life-saving, how do you call it, application. It is an online application. It's from the Netherlands. It's pretty new. It's version 1. But what it does, it prioritizes the literature found through the search that you've done. So I did my search with medical librarians, and we found another 2,500 publications, and we imported it in AS Review. And what it does, it prioritizes based on prior knowledge, and the prior knowledge I gave in was the selected literature from the original search. So I gave in all the full texts and abstracts of the original articles that I selected. And based on that information, it prioritizes the most relevant publications on top, so that you only have to, for instance, what I did was I scanned 200 publications instead of the 2,000. And there were at least, 50 irrelevant publications. That's the standard that you should follow. When you have 20 or 30 irrelevant publications, then you can stop the search, because it's unlogical that you find another relevant article. And it's based on active learning system. So if you include an article, then it's also used in a prior knowledge. So it's worth a check to
Yeah.
take
Thank you so
time
much,
on
Vika. I will
reviews.
definitively check that. Thank you so much for your presentation. Please stay with
Yeah,
us.
thank
Maybe
you.
there will be a discussion afterwards. And now I'm happy to move to our last presenter, Amy Faust. Hi, Amy. So nice to have you. Amy Faust is a health promotion manager at Bergen's Promise, a nonprofit social service agency in Hackensack, New Jersey, United States. Her background is in public health, health behavior change, and health education. She currently focuses on a program evaluation and integrates care for youth with mental health challenges. And today, you just see the title of her presentation, a call for cross-disciplinary clarity, health literacy of adolescents with complex healthcare needs. Welcome, Amy, and I'm looking forward to listen to your presentation, which actually also builds a bit up on the earlier presentation that were young children, and now we are learning something from adolescents. The floor is yours.
Absolutely. Thank you so much. Been learning lots today from our colleagues, so I appreciate everybody's time. Thank you for joining me. I'm honored to have this chance to share some of the work related to health literacy that my organization has been doing with the youth that we serve. Today, we're going to be talking about adolescents with complex healthcare needs. So our quick learning objectives for this time together, I will be describing the prevalence of low health literacy amongst the adolescents I serve with complex healthcare needs, and we'll be discussing the importance of applying organizational health literacy strategies across disciplines. So a little bit of background on my organization. My organization is called Bergen's Promise. We work with youth up to age 21 in Bergen County, New Jersey in the US. The youth that we work with are facing challenges related to mental or behavioral health, substance use, or developmental disabilities. We have an integrated healthcare program within our agency called the Behavioral Health Home. And that program serves youth that, in addition to these mental behavioral health challenges, are additionally managing a chronic medical condition. We've observed that many of the youth and adolescents that we are serving are taking leadership roles in their healthcare, whether by choice in some situations or a necessity of circumstances. And as we consider their interactions with the healthcare providers, we've sought to better understand the health literacy needs of these youth. We recognize that the youth we serve are facing multiple health literacy challenges. Not only are they expected to begin participating more in the management of their chronic health condition as they enter adolescence, but they are at the same time managing symptoms and treatment of a mental health challenge. So these youth are interacting with healthcare providers from multiple disciplines. These providers have different priorities, use different jargon, and typically have limited interdisciplinary communication. Therefore, our program at Bergen's Promise has been conducting the newest vital signs screening with our youth at enrollment to help us better understand the needs of the youth that we're serving, to tailor our health education materials, and to open up the conversation with youth on health literacy skills and communication strategies. So through our enrollment process, we have been compiling the results of these screenings using the newest vital sign to help us understand the health literacy needs overall of the youth that we're serving. And we want to share that with you today and some of the takeaways we've had from that information. So the sample that we are looking at today is a group of 184 youth ages 10 to 21 with co-occurring mental health and physical health challenges in New Jersey. These youth are enrolled in our behavioral health home integrated care program at Bergen's Promise, and they all completed the newest vital signs screening as part of the enrollment process. This data was collected over several years between 2015 and 2022, and we chose to limit the data to youth in our program between the ages of 10 and 21, based on some previous literature confirming the validity of newest vital sign in this age group. So the newest vital sign screening tool was verbally administered to our youth by a registered nurse or certified health education specialist during our enrollment process. As many of you may know, NVS is a 6-item screening tool based on the interpretation of a nutrition facts label. We have found it to be appropriate for use in the field. We do home visits with youth, so we're seeing them in their home environment, but we find it very useful due to its brevity and ease of administration. We analyzed the information from the newest vital sign screenings completed by enrollees at the time of survey administration. These youth were all between the age of 10 and 21, and we've used some descriptive statistics and non-parametric tests to look at the data and trends in our group. So this data describes our sample of 184 youth that completed our screening. Most youth fell in that 13 to 17 year age range with an average of about 15.5 years of age. Just over half of the youth identified as female. Not all youth disclosed during the enrollment process their identified race, but about a third of our population identify as white, 13% as Black. Just under half of the youth identified as Hispanic or Latino. We don't have socioeconomic status data for these youth on file, but we can report that all youth enrolled in our program have full Medicaid, which in the state of New Jersey means that they are at or below 350% of the federal poverty line. So the newest vital sign is scored by giving 1 point for each correct answer on the screening with a max score of 6 points. Scores of 0 to 1 suggest a high likelihood of limited health literacy. Scores of 2 to 3 indicate possibility of limited literacy, and scores of 4 and above almost always indicate adequate literacy. The mean NVS score for our population was 3.8, falling in that limited health literacy range. 42% of youth enrolled in our program had limited or the possibility of limited health literacy. This prevalence is similar to other studies of adolescent populations in the US. However, I will discuss a little bit further in a moment that the reasons that we believe that organizational health literacy and clear communication when interacting with this population is escalated due to the frequent interactions that these youth have with multiple disciplines. We did run non-parametric tests to explore relationships between our demographic information and NVS scores. We found no significant correlation between NVS score and age for our group. There were no significant differences by race, but as I mentioned earlier, race was not reported by all youth at enrollment. We used Mann-Whitney U test to look at differences in NVS score by gender and ethnicity. There were no significant differences in our male versus female respondents or Hispanic versus not Hispanic Latino. Additionally, we did have paired parent health literacy data from the NVS for a subset of 37 of these youth included in our sample today. We ran a Spearman's rank order correlation to look at the relationship between youth and parent NVS score, but no correlation was evident in this small subsample. That's something we'd like to look at further in the future with our larger sample. So while the prevalence of limited health literacy identified through our screening of these youth with co-occurring mental and medical health needs was comparable to prevalence data in other adolescent populations, we believe that it's essential to couch our interpretation of that data in an understanding of the complexity that these youth's interactions with the healthcare system. For example, a really common diagnosis for kids that we're working with includes diagnoses of obesity, asthma, and depression. So consider a youth with these diagnoses. She may visit her pediatrician in the morning and hear words such as elevated BMI, spirometry. She goes to the pharmacy and is given an inhaled corticosteroid. And then in the afternoon, she has a meeting with her mental health care team. And she's hearing words, selective serotonin reuptake inhibitors and cognitive dissonance and biopsychosocial assessments. What do all these terms mean? How do they relate to one another? The health literacy demands of this youth is magnified by the number of providers and the different systems that she's interacting with. The cognitive load of this information is overwhelming. And beyond the sheer breadth of healthcare communication that these youth encounter, it's important to recognize that youth with mental and emotional or behavioral health needs may also be impacted by impaired cognitive function as a result of the demands of their condition. The youth that come to Bergen's Promise come to us in crisis, and therefore we recognize that some of the mental health challenges they may be experiencing could be associated with poor cognitive performance. This may further limit their ability to process and collate all of this complex information from multiple providers. This highlights the importance of integrated care, which is a model that we practice here at Bergen's Promise, where providers from behavioral health and medical health disciplines work together to create clear, concise, and coordinated recommendations. So in conclusion, our newest vital signs screening data from our 184 youth between the ages of 10 and 21 indicate that about 42% of this population with medical and mental health care needs have limited health literacy. But due to the extensive interaction of this population with both medical and mental health care professionals, we believe it's essential for providers from all disciplines to practice clear communication to provide effective and actionable care. Our organization has taken several actions based on the results of our screenings, and we encourage others to consider how these may fit into their practice. We recognize our adolescents as active participants in their healthcare, and as such, our team incorporates health literacy skill building activities into their interactions with youth. We've witnessed the significant health literacy burden faced by youth with both medical and mental health needs, and as such, we've taken steps as an organization to examine our own communication and the accessibility of the information we provide to families. We believe it's important for providers from all sectors of healthcare to consider their organizational health literacy. And we think this conversation needs to apply not only to medical healthcare providers, but also behavioral and mental healthcare systems as well. We seek to bridge that gap between medical and behavioral healthcare, encouraging communication and information sharing to provide more consistent and coordinated care. We witness the value of this cross-disciplinary collaboration and encourage others to seek opportunities to improve these outcomes and accessibility through integrated care as well. And thank you for your time. I'd be happy to answer any questions you may have.
Thank you so much, Amy. This was a very great presentation, and I also learned a lot from the things that you shared that I didn't know before. Great. Let me have a look to the chat and also the Q&A board if there are any questions. And of course, if there are none yet, I have prepared some, but let me just check it. At the moment, there are no questions, but maybe people will post them while we are talking. You have collected data using the newest vital sign, which falls under the domain of functional health literacy, which pretty much makes sense, given the fact that you have also looked on psychological, cognitive, and behavioral problems. And you have applied this instrument in 10 to 21-year-olds. And so there are big differences between 10, 11, 12-year-olds and 19, 20, 21-year-olds adults. Can you tell us a bit more about the differences in needs they experience when they interact with healthcare providers, or also in relation to what they need regarding their personal health literacy?
Yeah, sure. So yeah, we do work with youth from age 3 to 21 in our organization. So we do see a really wide variety in needs of these youth. As youth are reaching that adolescent age range, we are seeing doctors having more one-on-one conversations with the youth. People are asking questions of the youth during healthcare appointments. Our system really values the youth voice in their care. And so youth are asked big questions about what's important to them and what direction they want their care to go. And so as part of that model, we want to make sure that our kids, even at that age of 10, are equipped to answer some of these questions and understand what's being asked of them. And as I mentioned, a lot of kids that are coming to us in crisis. So sometimes even those kids who are at that 21-year-old age range, they're coming to us with a lot of needs and a lot of unmet needs. A lot of times our care includes linking them to new providers and increasing the size of their healthcare team. But at the same time, a lot of these kids have not received the proper care that they needed in the past, and so they don't have the experience of those interactions. So we expected to see more of a difference by age group, but we didn't see that in our data. Some of it may also be with the newest vital sign. There's some little math problems in there that may be fresh in in the minds of those kiddos in algebra class.
Right. And you very importantly mentioned that they come visiting you while they are in crisis. Do you have any background information on them regarding their parents, siblings, anybody else, agents from their social network, in the sense of the distributed health literacy and how their health literacy could maybe help mitigating the problems they're experiencing?
Yeah, definitely. So we've tried to get a little bit of a feel for that. We're collecting this data in practice as we're out there in the field, but we do have some information from parents as well. We've tried to collect both parent and youth health literacy data where possible to try to look at some of those trends and relationships. We do have a variety of situations too. Some youth are coming to us in care, the system's care. They may not have those adult supports in their family as they're interacting with, foster care or other out-of-home placements. But we do find that there are often correlations between the needs of the youth and the needs of the family overall. And a lot of times parents are also going through their own mental health challenges and their own behavioral health challenges that sometimes are limiting their ability to play the key lead role in those conversations with healthcare providers. And so that's where we see a lot of these youth having to step up to fill in those gaps as well.
Right. And while I'm checking the chat and the board, there are no questions. Maybe a final question from me to you, and then we open the discussion so that the audiences can also ask the other presenters. You showed in one of your slides that during healthcare interactions, children and adolescents at least have interaction with 6 different professionals, right? And maybe they encounter much more professionals on their way through the system. So this calls for a multi-professional approach when we address health literacy of children and adolescents, right?
Right. Yeah, exactly. And that was just an example. Those are some common diagnoses that we see, some of those co-occurring situations happening. And, we see a youth with asthma and anxiety, and her anxiety over her asthma causes her asthma symptoms to increase, and her asthma symptoms increasing causes her further anxiety. And so without that conversation and understanding between providers, we don't see those long-term outcomes that we want to achieve for our youth. And we do find that, as I entered the social service field 8 years ago, joining this agency, the number of acronyms and words that I had to Google to find out who was talking about what was pretty out of this world. So just understanding that when we are talking between medical providers, behavioral healthcare providers, that we need to recognize what words we're using and how we can simplify and combine some of our recommendations so they're not we're not talking from different dictionaries, that we're working off the same playing field.
Right. And can you tie in organizational health literacy into that, what you just said?
Yeah, sure. So I know for our organization, we have been taking a hard look at our documents, what words we're using when we're talking to families, what words are used on our website, in our materials that we provide to families to explain their care, and trying to reflect on what we're saying, what acronyms we're using, to make sure that we have a clear and concise message. And then also, as we work with partners, we contract out to a lot of providers, trying to reinforce the importance of that in their communication with our youth as well.
Right. Thank you so much. Maybe Vike and Jennifer and Veronica now also can turn on their microphones and their cameras. And if the audiences have questions to them, we still got a couple minutes, 5-6 minutes left. Maybe there is one or the other very urgent comment or question that you would like to ask them. Yeah, 5 minutes left. But let me check anyway if there are any questions. I don't see no questions at this moment. But how about all of you give us just one takeaway message, one thing that you should that you think we should or anybody should apply? And maybe we just start with Jennifer and then Veronica, Vike, and then Amy. One very important message you would like to share.
Okay, building on a theme that I heard in the plenary session this morning, where she talked about the need for programs to address deficits in health literacy. Again, just focusing, of course, we need to measure it, but focusing on programs that are actually going to address it.
Right. Very, very cool. Thank you so much, Jennifer. Veronica, what's your takeaway message for us?
Yeah, I think building off of that, if there's programs for anybody, regardless of what their background is, I think coming from medicine is that we're recognizing that even in medicine between nursing and providers, there's a difference in health literacy in terms of the information we're giving out to families. So making that more standardized would be very helpful all around.
Right. Thank you so much, Veronica. And Vika, what's your takeaway message for us?
For me, it's, I guess, more in the public health and in the health promotion setting. They're not really the one program or the one setting, so that we could give some attention to that on the level of the public health promotion setting to promote health literacy in children for there. Yep.
Right. Thank you so much, Vika. And Amy.
I would just, second that discussion of organizational health literacy, but then promoting that across disciplines too with our partners to make sure that we're addressing things holistically.
Thank you so much, Amy. These are very important messages, and I will make sure to take them with me. We almost reached the end of our presentation. Following will be the break and the poster preview. And on 4:30 p.m. there will be 2 panels, C and B, on health information library within a level 1 pediatric hospital, and make your research count, learning from health systems, what is useful and what they need. Please make sure to attend it. I would like to thank the audiences and of course to you presenters, which really was amazing. I will make sure to access your presentations and also many of the studies that you referred to. Thank you so much. Live long and prosper. Bye-bye.
Thank you. Bye.